You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're looking at a biopsychosocial approach to paediatric mental health in emergency care with Kristina Maximous. So paediatric mental health presentations are really becoming an increasingly common part of pre-hospital care. Yet many paramedics and indeed pre-hospital staff report feeling underprepared when it comes to recognising and responding to psychological distress in children and adolescents. So unlike physical illness or injury, mental health concerns can often present subtly, evolve dynamically, and sit within complex family, social, and developmental contexts. So today's guest, Kristina Maximous, is a dual registered paramedic with extensive clinical and academic experience in both Australia and the United Kingdom. So she currently serves as a lecturer in paramedicine and academic resource lead, and is completing her PhD, focusing really on paediatric mental health screening and assessment within paramedic-led emergency care. So Kristina's research has explored how paramedics can make decisions about children and adolescents in psychological distress, and the limitations of current screening tools in dynamic, time-pressured environments. So Kristina's work aims to really inform a more developmental approach, looking at biopsychosocial approaches that support safer, more equitable care for younger people. So in this episode, we're really going to explore and dig into the distinction between screening and assessment, unpack the challenges paramedics face on the front line, and discuss what more holistic biopsychosocial models might look like in practice. Welcome to the podcast, Kristina.
Thank you so much, and thanks for the opportunity to be here. I think it's going to be a great discussion, and research is certainly needing to be expanded in this space. So look forward to the conversation, and thanks for having me on.
Oh, listen, it's a pleasure. It's great to have you with us. And I wondered, I guess as a framer and opener, Kristina, could I get you to maybe speak to initially why paediatric mental health is such a contemporary issue within paramedic practice?
Yeah, absolutely. So I think there's a number of reasons. From a clinical perspective, assessing children and adolescents is inherently complex. It's nuanced in many ways, particularly when we start to think about mental health crisis. So suicide attempts, suicidal ideation, self-harm, it adds another layer of complexity. Children often can't explain what they're feeling, and depending on where they are in that kind of age span as well. I mean, how a 10-year-old expresses themselves would be very different to a 17-year-old. But it's really important for us to recognize that distress can show up in different ways through behavior, emotions, or even changes in how that child interacts with their peers or friends, and the network around them as well. So that's something as paramedics I think we have to be more attuned to, our verbal and non-verbal cues. But we're also seeing more children in mental health crisis globally. The statistics are quite harrowing. And I think as paramedics, naturally we are the first point of contact, and we're expected to make a lot of decisions on risk and safety and care pathways. Yet there's no paediatric mental health screening or assessment tools that are available in our clinical practice guidelines across England and Australia for paramedics. So a lot of paramedics like myself feel quite unconfident when it comes to these really complex cases, and to be able to really support children. From an ethical standpoint, something that is quite concerning is in some guidelines we do see SAT tools, so sedation tools, where if you have a patient present with behavioral disturbances, for example, and you need to sedate them, there is a sedation tool. But for children, how can we even consider a sedation tool when we haven't actually got the tool itself to assess what the underlying problem is? So I think that adds another element, I guess, of some ethical complexity.
To your point around actually, gauging what a baseline looks like and understanding what good mental health looks like, but something which I would love you to speak to maybe is, the difference between screening and assessment in pediatric mental health, and I guess in a way why that distinction matters.
Yeah, so traditionally, I guess screening and assessment are considered quite two separate processes. You're absolutely right. But the boundaries of them in the literature aren't clearly defined. So specific to pediatric mental health, if you read a lot of the existing studies, they the terminology is used quite interchangeably. So they might be talking about a screening process, but they're actually using an assessment tool. So for the purpose of this, I guess, screening it's usually brief process, and it's to identify whether someone might be at risk. And in this particular context, we'd be looking at risk of self-harm or suicide. So if you were to go to the emergency department, you often see a lot of those screening processes happen at the start in the triage process when you first arrive, and the triage nurse kind of tries to identify what the imminent risk is for that patient. And the purpose of screening is to flag whether someone needs further evaluation or escalation of care. Assessment, on the other hand, it's a lot more broader. So in the context of pediatrics, it would explore more about the child's emotional state, developmental stage, behavior, the wider family, social context as well. And it usually happens a little bit later in the care pathway. So to put it simply, I guess, screening identifies risk, but assessment helps us identify the why behind the child's distress. And so even though assessment traditionally sometimes happens a little bit later in the care pathway, it's actually really important for us as paramedics, because sometimes we need to screen to identify imminent risk, but we also need a more thorough assessment to identify why this is happening, because that helps us make decisions around safety, transport, and referral. And something I'm really passionate about as well, with kind of expanding beyond just the screening, is that it helps us take a more child-centered approach. And we're not reducing that child to just a simple checklist of symptoms. We're actually understanding what's happening in their life in a more kind of broader context.
Yeah, I think that's fascinating and absolutely true. And to your point, it's sometimes not always possible, but sometimes the why behind indeed the root cause behind the distress, it sometimes is apparent, and actually with a little bit of digging or due diligence or indeed research, you can start to get to the why. But to your point around understanding, maybe if there is an organic cause or non-organic cause, being able to de-escalate and maybe remove some of those stressors, and actually, give a child chance to just, I guess in a way, calm down, just de-escalate. So I'd like to, as an adjoiner to that, Kristina, I'd like if you could articulate, because the dearth or lack of pre-hospital research here makes it difficult, and there is, I think, if you could expand on this, there is far much more research in the emergency departments and beyond in the hospital phase of care around pediatric mental health. Could I get you to speak to why that makes it challenging because of the sort of the lack of research within the pre-hospital domain?
Yeah, I think it's a really good question. And I think the answer is quite multifactorial. So paramedicine as a research discipline is still relatively emerging. So over the past, say, maybe 20, 30 years, we have seen a lot of strong development in research areas like resuscitation, trauma, critical care. And you being in that space, probably you've seen that research develop. But areas such as pediatric mental health have just not been researched very well. I mean, when I was looking at the research, I couldn't find anything pre-hospital in terms of pediatric screening or assessment specifically to that. I think another challenge that we have is that mental health research has traditionally been done in hospital, particularly the emergency departments. And it's a lot easier to conduct research in those settings because you've got relatively controlled environments, longer observation periods, clearer clinical pathways, which make data collection and tool validation a lot more feasible. Whereas in contrast for us in the out-of-hospital setting, it's difficult to study. Paramedics, we operate in quite unpredictable environments. Our contact with patients sometimes can be quite brief, and there are a lot of operational pressures to be able to conduct those studies. And I think it's not that we're not able to, I think we just need to approach it with a little bit more patience in adapting to the environment that we have as well. So I think a lot of tools have been developed for in hospital, we're aware of that. But the problem with that is it leaves us as paramedics expected to apply tools that weren't developed for the realities of our work. So I think there's a lot of work to be done in this space. And I think research in all areas in paramedicine is starting to really improve. And so I think it's just going to be a patience game. And I think in the next decade or two, things will look very different for us.
I just wondered if you could maybe unpack for us actually and speak to some of the major limitations, Kristina, of current screening tools. I guess in a way, when it comes to capturing the complexity, as you said before, of a child's psychological distress beyond sort of those overt risk markers like suicidality, and you know, the call might come down on the mobile data terminal, you know, feels suicidal, and that might be abundantly apparent. But there is maybe, you know, to your point, there's a lot of complexity which has maybe led to that state. Could you maybe just, you know, unpack for me and listeners really, you know, maybe some of those limitations that screening tools don't capture?
I think one of the limitations, and I don't know if it's the limitation is the right word, but many screening tools focus primarily on suicide risk or self-harm. So they're usually quite brief, and the questions around suicidal ideation or suicide attempts are structured within that kind of narrowly focused approach. Now, I don't think there's anything wrong with that. And I think those questions are really important. And so I'm not taking away or saying that they're any less important, but I think it's important for us as clinicians to recognize that children's psychological distress doesn't always present in that way. And it can be a lot more varied and a lot more subtle. So if you do have quite a narrowly focused tool and a child answers no to everything, then where do you go from there on? So, but for children, it's important to start looking at things a little bit more broadly. We see it through, as we mentioned earlier, behavioral changes, emotional dysregulation, withdrawal, and even conflict within the family. And these can be really early indicators that a child is struggling. Not necessarily that they're suicidal, but there's something within their well-being or their environment that needs a little bit more attention. I think another key limitation is that the tools don't really capture that kind of psychosocial context. A child's distress is influenced by a lot of things. It could be family instability, bullying, school pressures, social media, you know. Even when we had COVID, that had a massive impact on our paediatric population. And so those factors aren't always well represented when you've got a very narrowly focused tool. And the narrowly focused tools also don't consider kind of developmental differences. So what distress looks like in a 10-year-old, as I mentioned before, would also be very different to what it may look like in a 15 or a 16-year-old adolescent. So I think we're kind of reframing it in a way that it's important for us to understand that children's distress is complex, it's contextual, and it's developmentally influenced. And it's not always defined by this kind of immediate risk markers like suicidality. So it's not to exclude them, but it's maybe to broaden some of those questions out.
So, Kristina, could I get you to really unpack for us how a biopsychosocial lens shifts the way we think about mental health presentations in paediatric emergency care?
Yeah, I think it encourages us to move away from that kind of just narrow symptom focused view and instead look at the big picture. Globally, suicide remains one of the leading causes of death amongst children and adolescents, despite ongoing prevention efforts. And so for me, when I started my research and I was looking at these harrowing statistics, I'm like, but why? If we've had mental health reform, if we've had prevention efforts, why are the rates not improving? And so something that I think also might be a part of it is that each generation grows up with in a different social and environmental context. So for example, in our generation here now, we've got social media, we've got emerging technologies like AI that are now embedded in young people's lives. And in some cases, AI has been linked to suicide deaths, which is tragic. So some of these pressures are pressures that necessarily didn't exist in previous generations. And I think each generation has its changes and challenges. But I think if we want to respond effectively, our approach needs to evolve with the kind of generational change that we see. So I think the biopsychosocial model really helps with that because it encourages us to consider biological, psychological, and social factors in a child's distress. it's practical, and even with things changing year on year, it still allows you to kind of be able to broadly assess that child. And it helps us understand not just why a child is struggling, but how they got there and what might help them. And so identifying imminent risk is still critical, it's still important for us. But I think if we don't identify the underlying factors, we risk missing opportunities that could provide kind of more meaningful and more sustainable support for our patients.
So just pivoting slightly and in a way looking at more developmentally appropriate tools, Kristina, for improving, I guess in a way, on-scene decision making for children and adolescents in crisis. Could I get you to really maybe unpack that developmental appropriateness of tools and how we can maybe, yeah, just improve those tools to facilitate decision making?
Yes, I think developmentally appropriate tools can support paramedic decision making in several stages of care. So, if we're looking at the point of care, I think they help guide us to better understand what's actually happening for the child or the young person. That then informs our clinical decisions, whether it's assessing risk, recognizing underlying psychosocial factors, or deciding what type of care might be needed. From a patient and family perspective, they help us communicate in ways that I guess are appropriate for that child's age and development, and helps us build rapport and gather more meaningful information to guide our decisions, not from just the patient, but also from family members and caregivers. And lastly, I think during transfer of care, it allows us to, I guess, provide a clearer and more structured picture to a child's needs when handing over emergency care departments. Being able to know the risk of the child, but also knowing the why, helps our clinicians that we're referring to identify what services or what needs that child might require, which ultimately is not just child-centered, but it supports a kind of safer and more informed decision about ongoing care for our patients.
Yeah, I really like what you say there, and I totally agree. Looking at the primary caregiver to guide, to understand what the needs are, what the normal baseline is, what a normal expectation for cognitive and or motor function is, just, and not even dressing it up like that. Is this normal for the child? What is normal? Where how are they abnormal today? And just almost using accessible language, but gaining insight from their perspective as the enduring relationship and as the enduring primary caregiver. Could I get you to, there is, to your point, it's multifactorial and there are challenges. One challenge that some of your research highlights is inclusivity, specifically, the cultural piece, the linguistic diversity, and the neurodivergent children and those populations, which in essence we might get called more to, because if there is an atypical presentation from a neurodivergent child, that might spark an emergency call for us. So we are maybe almost seeing more of this patient population. Could I get you to speak to how should screening and assessment tools account for this cultural diversity, the linguistic diversity, and the neurodivergent diversity?
I think there are many ways, but I think we need to start right at the beginning, and we need to better educate paramedics in understanding the developmental milestones, and that will initially help us to also interpret behaviours more accurately. And cultural context is really important. I do think as paramedics we are good at, when we work within a certain area or region, I think we have great communication skills, and we start to understand a lot of the cultural context within the communities that we work in. But I'm talking specifically around both kind of verbal and non-verbal communication, understanding in children how distress is expressed, how it can be influenced by a child's background. So in some communities, mental health can carry quite a lot of stigma, which can shape how families communicate with clinicians. And so we have to kind of be attuned to some of those, I guess, cultural differences that exists. Another one is language. I think language is a part of that. English may not be for some families their first language, so tools need to be easily accessible but translatable. One example is the ASQ, it's the Ask Suicide Questionnaire, and it's a tool that asks kind of 4 questions around risk of suicidality. But they've done a great job in translating that tool into 14 languages, which is incredible. But when you look at the research, the hospitals that were using some of the translation of those tools were only using it in 2 languages. And so if something is a digital tool and it is translatable, why are we not having all of the languages accessible when they're needed? So that's something I think for us to consider. You touched upon in your question about neurodivergence, and I think that is another key factor in our education. So understanding conditions like autism and ADHD can affect communication. So for example, avoiding eye contact might be misinterpreted as disengagement. But for some children, that's quite typical. So I think once we understand the developmental milestones, we can then really start to ask those questions that are very child-centered to give us a better picture in capturing everything that child needs. So I think capturing it within a tool or one specific tool is really difficult. It's less about fixing everything, and I think more about using kind of a broader framework like the biopsychosocial approach to guide how we think and take a more child-centered approach overall.
So just looking at your scoping review, actually, Kristina, you identified many screening instruments, but I guess in a way few that align to a biopsychosocial approach. And I guess my question would be really, what would an ideal biopsychosocial approach aligned tool look like in practice at 3 a.m. on a out of hours in emergency care?
That's a really great question. And it's actually the next phase in my PhD. It's what I'm looking at right now. And I'm looking at whether we need to identify, adapt, or develop a tool that can better capture the biological, psychological, and social factors in a way that is meaningful for us in paramedic practice. So I don't know what that's going to look like just yet, but if you were to ask me kind of just objectively, I think the tool should have 4 components, I guess. 1, holistic. It doesn't just focus on one issue, but it looks at the whole child and what might be contributing to their distress. Number 2, I'd say developmentally appropriate. So it reflects the child's age, stage, and communication needs. It's practical for paramedics. I don't like to use the word brief because sometimes we use brief tools, but we're still on scene because these are complex cases for some time. But the tool fits the realities of paramedic practice in that kind of time-pressured environment that we're in. And the last one I would say would be kind of structured enough to guide clinical decision, to give paramedics the confidence to be able to know whether they're going to take this patient to an emergency department or they need to refer them to a mental health facility, and just making decisions by knowing a little bit more information around their situation and social environment and underlying stresses. And I think if we have those 4 components, it enables us to give a really great handover and hopefully encourage that kind of continuity of care, and it's not so fragmented.
So, in your scoping review, you denote, and I think it's a critical point, that validated pediatric mental health tools are often absent and aren't utilized and or available for paramedics. Could I get you to unpack for us really what interim strategies we could use right now to improve recognition and indeed response and fundamentally, I guess, decision making?
I think even without perfect tools, there are still practical things that we can do as paramedics to improve how we recognize and respond to children and adolescents experiencing distress. So I think 1, slowing the conversation right down makes a really big difference. When you're talking to that child, get down on the child's level. Giving a child a moment to speak and to feel heard often provides a really great insight into what actually is going on. And children need to feel safe and to be able to kind of share their experiences. So it's important for us to really think about that environment and bring a lot of calmness to what may feel quite chaotic for them. Asking open-ended questions is another really great way. So rather than just asking yes or no, questions can help us really understand that child's experience and what they're feeling in that moment. Speaking to the child's caregivers on scene as well is really important. They can provide valuable context on recent changes, routine disruptions, stresses. Things like that are really important. Being a parent myself, actually, someone recently said to me, for example, the transition between daycare and school, make sure that, you take the child to pick a lunchbox and that they can open the lunchbox, because once they get to school, it's a new school, new environment, and then they can't even get to their lunch, becomes a really stressful situation. And I never really thought of that or gave that too much thought, but what it taught me was sometimes we think some things are quite minor, but for children it's quite big, moving house or moving school or new pieces of equipment that they have to navigate. It's not always big things, so we've got to kind of keep an eye out for those things as well. Documenting observations clearly while it's fresh in our head, and that enables us to kind of be able to capture, behavior, mood, interactions, family and environmental stresses, if there's a safeguarding concern, and then being able to hand that over to our services with an accurate picture of what's going on. And hopefully that kind of improves the continuity of referral pathways and getting them into the right system early on.
So I guess my next question, Kristina, really is how we can start to embed some of these principles into paramedic education, because in practice, as you said, there's a real lack of tools and or strategies, but you've just denoted some fantastic ones there, actually. And your first point is absolutely gold: slowing the communication down, sitting alongside the child or getting down onto eye level, starting to ask open questions, and in a way build rapport. And that psychological safety is absolutely fundamental with the child. My question alongside that would be, you work as a lecturer in paramedicine. How can we adapt, change, and I guess in a way improve education for paramedics to reflect some of those points you just made?
I think as more research is coming out and we're kind of now into this space, we've got to start at the university level. And it's something I'm looking at the moment, but pediatric mental health needs to be embedded consistently across paramedicine curriculum and not just left to kind of on-road experience. And I'm not taking away, I think paramedics, with their experience do a really great job. We really do. But I think it's important to kind of build that foundation early on and ensure that clinicians are better prepared to respond and recognise these presentations in practice. And so part of the education is focusing on understanding not just risk. I think we're very much in that risk space at the moment, but education needs to emphasise child development and how stress presents around different ages and stages and cultures and contexts. And it helps us paramedics, as I mentioned before, just move beyond that kind of constant checklist and better interpret behaviours in the context that they're presented in. I think as well, strengthening communication with families and training support for clinicians in asking meaningful questions and using parents and caregivers as key sources of insights. Having guidelines that support us in providing information like what is normal versus what is critical in assessing risk as well. And I think education doesn't stop at graduation. Once paramedics are on road and they've qualified, then we need to also lean into our paramedicine colleges for professional CPD, continuous professional development, and also for our ambulance services to keep continuing the conversation and embedding the training, just like we do with regular, resuscitation and trauma training. Pediatric mental health needs to be embedded into those kind of continuous professional development. So one's education, and then one's obviously, I think, the responsibility of our university and our paramedic colleges out there.
Yeah, fantastic. Absolutely. I couldn't agree more, actually. So, an adjoining question, and just as we come into land, just a couple more questions. One, Kristina, would be around integrated care pathways and I guess, yeah, system level collaboration. And could I get you to maybe unpack for us how, that can play a fundamental part in improving continuity of care after that first point of contact? Because to your point, the emergency department may or may not be the most appropriate place for a scared child, which is really maybe at the edge or beyond their level of capacity and ability to cope. And, putting them into a busy, frenetic emergency department on a Friday night isn't necessarily the right place for them. Could I get you to speak to these integrated care pathways and maybe in a more appropriate place of care for these patients?
Yeah, so I think paramedics, as we know, are often the first point of contact for children and families in this particular situation. But we can't solve everything in a single encounter. And I think this is really where integrated care pathways and strong collaboration across services become really important. I think when systems are well connected, they help ensure that children have appropriate referral options, continuity of care, and access to the right support after that initial interaction. And I think what we're lacking at the moment is there might be some systems once you're in the hospital in terms of their escalation process, but there's so much fragmentation between the out of hospital setting, and specifically here paramedic-led care, and then once you enter often the emergency department. So if we see a child, we do our own assessment and judgment of where they need to go. And then once they get to the emergency department, then they go through a different triage system. And then they might see the doctor on call, and that's a different process. And it just is this constant fragmentation that I think impacts our children. When we think about physical health, it's not the same. In physical health, we start a process, and when we transport that patient into hospital, they continue it. So we need to work better between in-hospital and out-of-hospital services. And it can also, reduce the amount of unnecessary emergency department transport in situations where maybe we can access services that are better suited to support that particular child and their family. But I think achieving this requires collaboration across our health system and our social care system as well. And I think when we get there, hopefully it's going to create a more kind of coordinated and supportive journey. And so I emphasize that point because I think it's not just about the tool. I think the tool and us developing a tool or creating a tool is one really small component of this research. Because even if we find the perfect tool, but everything else is fragmented, it's going to be really hard to see those positive results. So I think we all need to kind of come together in a more coordinated manner and do what we do as we see in kind of physical illness and trauma.
So just finally, as we come into land, Kristina, looking forward, what research, to your mind, or indeed implementation priorities, should the pre-hospital care community focus on really to promote equitable, child-centered mental health?
Yeah, I think looking ahead, I'd say maybe just to summarize it in quick, there's lots to say, but 4 take homes would be: 1, strengthen our education and training. So as I mentioned, embed pediatric mental health across university programs, reinforce it through the ambulance services in our colleges. And this builds confidence in paramedic-led care and us and our ability to manage complex presentations. Develop not just a tool, but our clinical guidelines. We need better screening and assessment tools specifically that are validated and reliable in the out-of-hospital setting and that are clinically appropriate as well. And that leads us to developing the clinical guidelines. So the tool is one component, but we do need clinical guidelines to help us navigate through these complex cases, referral pathways. And the last one, as we were just talking about, would be enhancing our system integration. So better coordination across services is essential to reduce fragmentation, strengthening our communication, referral pathways, follow-up care, and just kind of that continuous journey to be connected and to help improve the lives of children and their families.
Listen, that's fantastic, Kristina. And what we'll do in the show notes is put links to some of your fantastic research and scoping reviews and indeed work in this space, because I think it's such an important, as we were saying before, mental health and adolescent pediatric mental health is on the rise. And it's such an important aspect of care that we need to both focus on and promote in a multifactorial way. So we'll put links in the show notes so that people can both reach out to and read some of your work. But listen, I just want to say thank you for the past 45 minutes. It's a privilege to really walk through this with you. Thank you.
Thank you. Thank you so much.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.